Assalamualaikum.
Waalaikumsalam.
Waalaikumsalam.
Semua dah ada ke? Dah semua dah ada lah? Dah. Okey, sorry lah saya sebut sekejap saya buka slide sekejap. Actually slide ni dah lama lah, rasa macam dah 2 tahun. So anything yang any recent findings or recent evidence in the past 2-3 years maybe tak ada lah dalam ni. Anyway, there's not many study lah done on neonatal sepsis. So I presume it should be about the same lah. Okay, sekejap ni. Kita mula dengan mula kitab Al-Fatihah tu. Alhamdulillah, wassalamu ala asyrafil anbiya'i wa ala alihi wasallam. Sekejap. Masih phone lah. Okay, nampak kan slides kan?
Nampak doktor.
Okay, sekejap. Okay. Sekejap. Okay, assalamualaikum warahmatullahi wabarakatuh. Okay, so basically today lecture is neonatal infection and neonatal sepsis. So definition of sepsis is clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. Okay, remember the sign and symptoms. Okay, they just a syndrome. Syndrome is collection of symptoms. A combination of signs and symptoms of infection, okay, with or without accompanying bacteremia. Maksudnya with or without positive culture that occur in the first month of life. It can be, the source can be many lah. It can be septicemia, can be meningitis, pneumonia, arthritis, osteomyelitis, and so on. Okay, this is the most common cause of neonatal mortality, okay, which is about 30 to 50%. Okay, about 1% of them will die lah. Primary sepsis, the incidence is about 1 to 5 per 1,000 live birth. Okay, it's much higher in prem. So it's inversely proportionate to human gestation. So the lower the gestation, the smaller the baby, the higher the risk of having sepsis. Okay, so do the mortality rate lah, the vice versa, inversely proportionate. So features, okay, usually they are very non-specific features. Okay, early sign would be subtle non-specific such as hypothermia or fever. Tapi remember, hypothermia is more common in baby lah compared to fever. Lethargic, poor cry, feeding intolerance, autonomic dysregulation such as bradytachycardia, respiratory distress, and metabolic disorder lah macam hyperglycemia or hypoglycemia. Usually the features related to various systems lah, depend on the source of infection. So it's either CNS, cardiac, respi, GI, or anything. Okay. It depends on which organ affected. Okay, when you talk about sepsis kan, the progression is at the end, towards the end is actually multi-organ failure kan. Macam just like adult lah. So they get sepsis. Initially there's a locus of infection, and finally it's become bacteremia, and then it spread and involve multi-organ. Okay, so it depends. It depends on which stage are you talking about. But usually after a while, they'll get multi-organ failure, so the presentation will be more systemic. By the way, you dengar kan? You guys dengar?
Dengar doktor.
Okay, kalau ada soalan just shout je lah. Okay. Okay, in general it's divided into two, early onset, late onset. So early onset, it depends. Some author or some study they put 24 hours, but in general usually we say it's 72 hours. So the main difference between the early onset and the late onset is actually the early onset, the pathogenesis is actually infection from mother, from maternal. Either vertically transmitted in utero or transplacenta kan, transplacenta or vertical transmission lah from placenta or from genital tract. Okay. The late onset is something acquired from the environment. Okay, it depends. If the baby is from community kan, kalau baby actually from outside, from home, then the source of infection is actually from the surrounding lah, from community. Tapi if the babies get infection while in the hospital, then they usually get nosocomial infection. So the organism will be different, the antibiotic use also different lah. Okay, epidemiology I've mentioned just now. Then presentation, usually early onset they presented with pneumonia lah, pneumonia, respiratory distress. Late onset, it depends. Okay, late onset can be pneumonia, can be meningitis, can be UTI, can be anything. Okay, but again, one of the most common is actually pneumonia lah. The characteristic, okay, again, risk factors for early onset is prematurity, maternal illness, mental infection. So if you look at the column, the first column, mainly are actually maternal risk factor, okay, rather than baby risk factor. Risk factor for baby is actually prematurity, low birth weight. Okay, for late onset, the risk factor, again, there's a baby risk factor, and also the surrounding risk factor. For example, admission to NICU, intervention that we did, the invasive procedures that we did kan, macam intubation, ventilation, the lines, central lines semua tu lah. And then for community acquired, usually it depends. For example, sometimes RSV is more common, dia ada seasonal kan. So in seasons where RSV is common, then they'll get RSV. So seasonal. Biasa tu poor hygiene lah. Okay. Sekejap. Okay. Etiology, okay, early onset because mainly come from mother kan. So it's GBS lah, the most common. GBS, E. coli from genital tract. So genital tract, you ada E. coli, you ada GBS. And then you've got gram-negative rods lah. These are all from you punya GU tract. And then the rest is mother lah, from mother. For the late onset, again, GBS can also cause late onset. Okay. Viruses can cause late onset. In terms of bacteria, HIV, it's no more common lah. Pneumococcus lah, meningococcus. Alhamdulillah. Treatment, we will discuss later lah. Okay, any questions?
Doktor, nak tanya. Kiranya yang classification tu dia untuk neonatal sepsis ke ataupun untuk congenital pneumonia?
Untuk neonatal sepsis, congenital pneumonia, okay, congenital pneumonia as the name represent, congenital kan, means it's acquired from the congenital lah, perinatally acquired. So congenital pneumonia is an example of early onset sepsis. Faham tak? EOS. Faham kan? So contoh baby, you ada baby, you dah discharge baby. And then at day 14 of life, They admitted. When we talk about neonatal sepsis, we are talking about sepsis that occur in the first 28 days of life. So, for example, if you've got a baby 14 days old, can admitted to you to NICU with signs and symptoms of sepsis, with or without bacteremia. So you say this is neonatal sepsis. Okay, contoh dia datang dengan respiratory distress. When the baby came with respiratory distress kan, you don't diagnose congenital pneumonia. You diagnose community acquired pneumonia. Faham kan? Faham tak? So you diagnose community acquired pneumonia. Congenital pneumonia is an example of early onset sepsis. Okay. Okay. Okay, differential diagnosis. What are the diagnoses that you can think of? Baby who came with signs and symptoms of sepsis. Okay, anyone? What are the signs and symptoms of sepsis in neonates?
Hypothermia.
Hypothermia, okay. So what are the differential diagnoses for hypothermia? Contoh baby too well. Okay, baby, I mean you've got a baby lah in NICU, admitted for example, mother ada GBS. And then suddenly, atau admitted for observation because of maybe mother ada DM. And then suddenly develop hypothermia. So what could be the differential for hypothermia? Iatrogenic kan? Contoh maybe kita off warmer ke atau the environment is too cold. Okay, so besides that, apa lagi signs and symptoms of neonatal sepsis?
Lethargy.
Lethargic. Okay, so what are the differential diagnoses for lethargic?
Hypothyroid.
Hypothyroid, okay. But it's not that common lah. Neonates hypothyroid dapat lethargic. Lagi?
Anemia.
Anemia, kan? For example, maybe baby tu lahir dia ada fetal maternal transfusion ataupun dia ada some bleeding daripada placenta previa ruptured kan? Ataupun rupture placenta. So baby yang hypo definitely nampak, baby yang anemic maybe nampak lethargic. There can be tachycardic. So it's very, it's cross kan? It's cross with neonatal sepsis kan? With sign and symptom sepsis. So that's why the differential diagnosis of neonatal sepsis usually depending on the presentation. Okay, kalau dia present with tachycardia, so differential dia would be neonatal anemia. Kalau dia presented with lethargic, it could be metabolic problem. Kan? Contoh macam metabolic lah, urocycle defect in crisis ataupun contoh datang dengan hypoglycemia, could be GSD, it could be fatty acid oxidation defect. So there's a lot of differential because it's very vague. Okay, faham eh? Okay, so investigation, again, all sepsis, the main investigation is culture kan. So culture can be from anywhere. You have to take culture from the most suspicious site. Okay. For early onset sepsis, most of the time the presentation is pneumonia, okay, and sometimes bacteremia. Okay, that's where the focus of infection. So usually for early onset sepsis, we will do blood culture. That's it. It's very rare for a baby to get sepsis from UTI at early age. So the first 72 hours of life, it's very rare for a baby to get UTI at first 72 hours of life. Sometimes it's very rare for a baby to get meningitis during the first 72 hours of life. So for early onset sepsis, you only take blood culture unless you have high degree of suspicion. For example, baby lahir with very ill fitting kan, lahir day one of life fitted. They fitted ataupun very lethargic, obtunded, apnea, persistent apnea, then you may think, oh, this possible ada meningitis. That the onset is actually occur maybe in utero punya meningitis, kan, perinatal infection that cross placenta, then the infections may start early in utero that causing meningitis. Then you can take LP lah, you can do LP. But in general, you do blood culture for early onset sepsis. But for late onset sepsis, it can be, the source can be anywhere, kan? Because late onset means it is acquired and it takes time to manifest. So when it takes time, it can actually be there, kan, in your blood. The infection may already be there in your blood for quite some time. So it can actually migrate to everywhere. So you can get meningitis, you can get UTI, you can get from abdomen, kan? So that's why in late onset sepsis, the investigation is more thorough and is wider. You do more. Okay, so you do LP, you do urine culture. Okay, faham tak? So nama panca I'm not going to tell you. I rasa benda sama je. You can read this. Okay, normal results number puncture in neonates. Okay. Okay. One of the causes of neonatal sepsis, okay, either early onset or late onset, okay, is herpes, okay, herpes meningitis, herpes encephalitis, sorry. Herpes infection can cause early onset or late onset. It depends on when the mother get it. Okay, if the child get it, if the baby get it ex utero, maksud dah keluar, then they get it from their siblings, kan, then dia akan dapat late onset sepsis secondary to herpes infection. But if the mother got herpes, okay, especially at third trimester, then the child can get herpes through transplacenta transmission. So they can get neonatal herpes as well. So usually in herpes encephalopathy, they can have bloody xanthochromic CSF. So when we do LP, you can get blood lah in the LP, in the CSF. Okay. So ada investigation for late onset, you can send urine culture. Okay, radiology, of course, chest X-ray, depending kalau ada apnea, ada distress, then you can do chest X-ray. Abdominal X-ray, depending also cranial ultrasound. Okay, management is supportive. Supportive means we support baby to prevent complication. Okay, and we support baby based on what the presentation is. Okay, for example, baby hypo, then you give high calorie lah. You give high calorie infusion. High calorie parenteral nutrition ataupun enteral nutrition. Patient with abdominal distended, then you keep nil by mouth. Okay, patient with respiratory distress, you give respiratory support, and if need be, then you need to ventilate. Okay, patient in shock, you bagi volume expansion, inotropes, hypoglycemia, you bagi itulah calorie. Patient with anemia or patient with bleeding disorder, kan, because of marrow involvement, they've got bleeding, then you have to support with transfusion ataupun blood product. Okay, for antibiotics, it depends. For early onset sepsis, kan, early onset sepsis. Okay, early onset sepsis, what is the most common causative organism untuk early onset sepsis?
Group disruptive focus.
Okay, GBS. So GBS, you nak bagi antibiotik apa? For GBS. GBS is a gram? It's a streptococcus, kan? It's a streptococcus, so it's a gram what?
Gram positive.
Positive.
Gram positive, kan? So you nak bagi apa? So apa you nak bagi? It's a gram positive, so you nak bagi apa antibiotik? With penicillin. Okay, so you bagi C-pen lah. C-pen ke ampicillin, anything lah. So you just give penicillin. Okay, lepas tu, the second most common is, tadi GBS most common, second most common is?
E. coli.
E. coli is a gram what?
Gram
E. coli is a
negative.
gram?
Negative.
Gram negative, kan? So you need antibiotic that can cover both lah. So if either you give a broad spectrum, which usually we don't practice, so what we give is we give two narrow spectrum. Alamak, sorry. Sekejap. Aku kata something lah, sekejap. Okay. So untuk gram negatif, kita bagi antibiotic that has good coverage for gram negative, narrow spectrum, so which is the aminoglycoside lah. Kita bagi gentamicin. Most center they give Cpan and Genta for first time. But this is applied only for early onset sepsis. Okay. For late onset sepsis, usually the common organism are those nosocomial microorganism. Faham tak? Hospital acquired microorganism. Contoh apa? Apa organism yang common dekat ICU? Apa contoh organism yang common kat ICU?
Pseudomonas.
Good. Pseudomonas. So Pseudomonas nak guna apa? Nak treat?
Cephalosporins.
Antibiotic. Which type of cephalosporin?
Kelas 3.
Yeah, so usually kita bagi third generation lah. Tapi actually Pseudomonas biasa kita bagi fourth term. Okay, fourth term ceftazidime. Which is a third. Ceftazidime is a fourth generation kan? Ke third? Third kot. Okay. Lagi apa lagi? Apa lagi? Common organism. MRSA kan? So MRSA kita bagi apa?
Cloxacillin.
Vancomycin.
Vancomycin kan? Nama pun MRSA. Medicine resistant. So kita bagi vancomycin. So it depends on your suspicion. So if you got a baby kan, yang dah more than 3 days in the ward, and then suddenly develop signs and symptoms of sepsis. So you have to treat the child as late onset neonatal sepsis. Kan? So how do you want, what antibiotic you should give? It depends. Kalau dah 3 hari dekat dalam ward, patient ada central line, patient ada intubation, intubated, kan? Dan intubated, dia prone to dapat Pseudomonas. So you have to cover with cefotaxime, for example. Cefotaxime, fourth term, things like that lah. At least third generation cephalosporin. And then, dia ada banyak line. So you may think of, MRSA could possibly the culprit. So you have to cover with vancomycin. So rather than you start Cpan and Genta, you have to start something else that will cover most common organism. Kalau patient daripada luar kan, for example, baby 14 days old daripada outside came in with respiratory distress, chances are they've got virus lah. Most common is virus, RSV, adenovirus, influenza, okay, ataupun they can get bacteria such as committee punya bacteria lah, Strep pneumonia kan, atau chlamydia pneumonia. So it depends on your degree of suspicion. So the best antibiotic would be antibiotic yang cover untuk community acquired, which is macam augmentin ataupun penicillin group lah, penicillin group. So kalau you rasa contoh ada parents, ada siblings pun ill, sounds like pertussis, then you cover with pertussis lah, azithromycin. Okay, faham kan? Okay, duration depending on culture. Okay. Okay. Probable sepsis is when you've got the sign and symptoms, and then you've got the marker. Contoh, total white dia high, CRP high, but there's no culture. So probable sepsis ni sama macam sepsis, but there's no culture positive. So you call it probable sepsis, and you have to give an antibiotic at least 5 to 7 days, depending. Okay. So in general, when you want to start antibiotic, you have to remember the neonates are immunocompromised population. Okay, they are immunocompromised people. They don't have immune system. So you have to have low degree of suspicion and low threshold to start antibiotic. So whenever you've got a child, a baby, neonates with any suspicion of sepsis, you have to start antibiotic. Okay, if they've got risk factor, more than one risk factors, then you have to start antibiotic. Atau you have strong suspicion. So baby ni well, no risk factor, tapi tachypneic, then definitely you can start antibiotic. Okay. Management, macam I mentioned tadi, is supportive, empirical antibiotic. Okay lah. Yang lain ni you boleh baca lah kot. Salah ni. The second sentence salah. Okay. The rest ni rasa tak perlu dapat. Tak payah. And you can baca lah. Just read a bit about HSV because it's one of the most common viruses lah yang attack neonates. And they've got a long-term sequela lah. So you need to have a low threshold to treat HSV. Usually HSV they're presented in 3 ways. They can present it with SEM lah, skin, eye and mouth punya lesion, ataupun generalized bacteremia. So they can with sepsis, or they can come with encephalitis. So this is the 3 presentation of HSV. Okay lah. Sana ni, this is let. Kalau another one is for herpes kan. The herpes you can send EEG, you can see PLED, the posterolateral epileptic discharge. That is quite specific for HSV. And then MRI, see the lesion is almost always at the posterolateral. It's actually lateral and then posterior lah. Usually it's a bit lower lah. And then treatment is acyclovir. Okay lah, tu je lah. Any questions?
Doctor, how do we know that the patient is response to the antibiotic given? Do we have to repeat the blood culture after the duration of antibiotic?
Okay, when you need to repeat blood culture, first, if you got positive blood culture, if you got positive blood culture, and this is confirmed sepsis, then usually you have to repeat after 2 to 3 days, at least 72 hours, around 72 hours of antibiotic, then you have to repeat. Okay, if still persists, then you have to change antibiotic lah. You know, it doesn't work. Okay, itu satu. Second, if patient develop reinfection, I mean new signs and symptoms, ataupun patient not responding, despite the 72 hours 48 to 72 hours antibiotic, patient still got signs and symptoms of sepsis, still in sepsis lah, still tachycardia, still respiratory distress, then you may need to repeat culture to see whether you can get possible there's a resistant organism or possible you've got new organism. Okay. But in order to know whether whether patient responding to antibiotic or not is by clinical. Antibiotic by clinical. So culture can only tell you whether you get rid of the organism, provided you dapat the organism from first place from first culture. But to yield a positive culture is only about 30%. So most of the time we don't have any culture pun. This is what we call empirical antibiotic. Means we give antibiotic that we think will suit patients. Faham tak? Empirical treatment is we give antibiotic that we think will works for the patient depending on the risk rather than depending on the proven culture. Okay, faham kan? Okay, ada soalan lain?
Doktor nak tanya untuk yang HSV pula sebab saya terbaca dia cakap yang HSV ni kalau infected, it is possibly fatal. So macam
Apa dia?
kalau baby tu infected with HSV,
Huh?
majority dia akan fatal.
Sorry,
Jadi
cabut.
my
Apa dia?
option for the
Kalau baby tu infected dengan
kalau
HSV,
yang
pasal?
baby dia fatal, maksudnya regardless of the treatment dia akan fatal juga. So
tak lah.
betul ke doktor macam tu?
Dia depends when you infected with the HSV. Kalau you've got the infection, if the baby got the infection, okay, at the third trimester, okay, usually at the third trimester lah, usually the outcome is very bad, okay. Tapi kalau dia get infection, the baby get infection ex utero, means after delivered dia dapat infection. Usually the outcome is not so bad lah. Maksudnya postnatally acquired is not that bad, okay, compared to perinatally acquired. Compared to antenatally acquired. Kalau dia acquired antenatally at third trimester, that is the worst. Okay, kalau dapat waktu perinatal means waktu deliver, mother dia ada skin lesion kan dekat genital herpes kan. So baby dapat acquired from genital herpes, contact with genital herpes. Usually that one is medium risk. Okay. Tapi kalau dapat in utero, then usually very bad lah. Kalau dia dapat ex utero, contoh for example dapat daripada adik-beradik ada herpes, cium and then dapat, then usually is better lah daripada dapat dia ada tu. Little ni biasanya kalau dapat in utero, prenatally acquired, yang bukan prenatal, yang antenatally acquired, yang tu yang teruk. And however, most herpes infection yang perinatally acquired, okay, kebanyakannya diorang akan jadi, the most common complication is deafness, sensory neural deafness. Okay, ada soalan?
Doctor, do we also routinely send for PCR if the
PCR
culture
of what?
is negative?
PCR of?
Or like RSV and HSV?
When you say routine, it depends. First, you have to have high degree of suspicion lah. Satu. PCR ni dia very specific. You cannot send, I want to send PCR for all organism. No, there's no such thing. So it depends what you think. Kalau you have a high degree of suspicion, this is herpes, then you take lumbar puncture, you send PCR from the lumbar puncture, from the CSF. Ataupun you send PCR, lumbar puncture PCR ataupun blood PCR. Tapi spesifik lah for specific organism. Kalau contoh you rasa this is a respiratory viruses, then you boleh hantar PCR untuk respiratory viruses. Tapi again, you need a high degree of suspicion lah. Faham tak?
Okay.
You cannot simply send everything lah, because it's not cost effective. And bila you ada that suspicion, you kena treat. Faham tak? Okay, ada soalan?
Okay.
Lagi soalan? Okay.
Doktor, saya nak tanya, kalau untuk yang RSV, ada ke kita bagi prophylaxis for macam baby yang delivered less than 29 weeks ataupun baby yang ada underlying chronic lung disease?
Yes. Okay. I mean, there's evidence that because we know RSV in baby with respiratory or in cardio or neuro punya, with underlying respi, cardio, neuro punya comorbids, they can become very bad lah. They can get very bad from RSV infection. So most physician will give prophylaxis immunoglobulin lah, against RSV to baby, to this high risk baby. Tapi it depends on availability to number one. Okay, number one depends on availability. Number two is RSV in the Western countries, in the cold climate country kan, they have seasonal lah. They are seasonal. Usually it's more common in the winter rather than in other season. But in country like Malaysia, okay, apparently study in Malaysia with surveillance of RSV in Malaysia, we found that in Malaysia there are also seasonal of RSV. Yeah, RSV is more common during the wet season lah. Contoh kalau Pantai Timur, November to March is when RSV is more common. Okay, tapi kalau Pantai Barat, you can't really tell the trend lah because you tak ada proper wet season kan. Tapi still RSV is advisable to this high risk population. RSV punya vaccination. But remember, we are not giving vaccination now. We give immunoglobulin, okay, a passive acquired immunity, which can only last for at most 1 month. So you need to give monthly injection. Okay, for example, kalau during the season kan, ada 5-month season, then you need to give monthly injection to this baby, and one injection costs you 3,000. So total of 15,000 per year. So Malaysia memang tak ada duit lah nak bayar that. Okay, but good question. Remember, one of the management of child, a baby with chronic lung disease, contoh SMA kan, baby ada chronic neuro punya problem, hypotonia, or baby yang ada congenital heart disease, especially sciatic heart disease lah, complex sciatic heart disease, we give palivizumab. It's a monoclonal antibody against RSV. So we give palivizumab during the season lah, during the wet season. It's a monthly injection. Okay, soalan. Okay, kalau tak ada dah lah. We can stop here. Okay. Okay kan? Okay, kalau you ada soalan, just text me lah, just WhatsApp. Okay, so tanggungan tasbih kafarah lah. Okay, soalan, ada soalan? Tak ada? Okay, tangguhlah tanggungan tasbih. Okay, tanggungan tasbih kafarah. Suatu nas. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Okay.